It's really a pleasure to get to speak with you all, and I'm really grateful for the invitation. I'm learning so much already from all of your experiences elsewhere in the world. As Paige said, I'm going to speak on understanding food security as a social determinant of health during pregnancy, and in particular to think about how we can take what we know about the epidemiology and lived experiences of food insecurity and food security and turn that into action for our patients and clients. I have no conflicts of interest, but I do have funding from various US-based federal and foundation resources. Um, and my objectives are to understand food security and food access as a social and structural determinant of pregnancy health, and then, as I said, to consider the clinical and research implications. But before I get into that, I want to tell you a little bit about my positionality. So, I've been thinking a lot about positionality as a researcher and as a physician as I proceed through this work. And I want to tell you about where I'm from. Chicago is a large metropolitan area in the United States in the Midwest, and you'll see where we're situated, which is relevant to a couple slides from now. But diving into that middle figure is a map of my city. Chicago is a huge city with 77 neighborhoods, which has dramatic segregation and poverty in some of them. Chicago is one of the most segregated cities in the upper part of the United States, and some areas in this west side and south side are particularly affected by poverty, violence, gun violence. You may have heard about this in the news, and then food insecurity, which is very intersectional with all these other determinants. Yet I work, and where I am right now, in this gleaming, beautiful 16-story women's hospital where we do 12,000 births a year. And so thinking about the intersections of the clinical experience in a beautiful, large downtown academic hospital versus the complexity of the environment I'm in, I think is really relevant to what we're talking about today. So I don't think we need to dwell much on food insecurity definitions and context, but I want to speak about these particularly as relevant to pregnancy and to the United States. We all know that food insecurity is a household level economic and social condition of limited or no access to adequate food, and this is true in pregnancy as well. The definitions are not different. What's interesting is that hunger, an individual physiological condition that may result from food insecurity, can have different manifestations during pregnancy when people have different nutritional demands. Yet the concept is the same, that it is a most extreme level of food insecurity. I also am going to talk a little bit about food environments. So this is the concept of healthy food access, having stable availability of nourishing, affordable, and suitable foods. And within that concept of healthy food access is the idea of low food access areas. We used to see this reported as food deserts, but really in the United States, at least, that's become a fairly stigmatizing term. And we try to say low food access areas instead of food deserts. These tend to be measured by the U.S. Department of Agriculture as areas that are both low income and low access to supermarkets or larger grocery stores. In the United States, the prevalence of food insecurity in households with children is very high, 17% in the 2022 surveys, and it's actually about 13% in households without children. I always think that number is a bit shocking and really speaks to the problems with our United States welfare systems or lack thereof. And then thinking about context and the geography of food insecurity, this is a map of the US showing how food insecurity varies by region. I could put up almost any map of any adverse health metric in the United States, and you would see that the Southeast, the South, and Texas are particularly affected by racial disparities in health metrics, poverty, and other and other adverse health outcomes. And it is no different for food insecurity. So we see that in the US, food insecurity varies by region, but it overlaps significantly with racial disparities related to structural racism. Thinking about specifically pregnancy, my area of expertise, I want to think about how pregnancy is a unique period for food insecurity for a few reasons, which will be all fairly obvious to this audience. But not only is there expanded energy and nutritional requirements, but there are also greater financial demands during pregnancy as a person is preparing for their future social role change. In addition, there are employment limitations. Many people in the United States, if not most, do not have adequate paid family and maternity leave. The need to go back to work early in order to have money to feed the family is a profound problem with food insecurity during and shortly after pregnancy in the United States. The number of patients I have going back at 2 weeks, let alone 6 or 12 weeks, is astounding, and it is almost entirely because of food and housing insecurity. The changing social role is very important to food insecurity, and Danielle spoke about that a little bit already. And then we also know that there's an increased risk of exposure to violence, housing instability, and resource withholding. I think that's particularly, as Danielle already commented on, relevant to our pregnant people who might be at risk of losing resources if they're controlled by another person in the household. And then finally, on the plus side, pregnancy is a unique period because of increased access to healthcare and social resources. In the United States, many people don't have health insurance when they are not pregnant. And the most underserved individuals in the United States might not have good access to healthcare outside of pregnancy. So entering our healthcare system during the antenatal period can offer an opportunity for intervention, or what I see as a window of opportunity to change the life course. How common is food insecurity during pregnancy in the United States? So this paper came out last year in JAMA Network Open and looked at data from what's called PRAMs, or the Center for Disease Control, CDC's annual surveys directly of pregnant and postpartum people. This survey only looked at 14 states. It was pre-pandemic data, 2004 to 2020, and they showed that on average, about the adjusted prevalence was about 9%, and it got down to as low as about 7% in 2020, but still nearly 1 in 10 pregnant people experiencing food insecurity during pregnancy. As you can imagine, emerging data have shown that these numbers went up significantly during the pandemic. So what are the ways in which we can think about food security as a critical social and structural determinant of perinatal health? I want to situate the concept of food security in a conceptual model, how I usually think about this when developing and testing interventions. In the US, we have Healthy People 2030, which is the Department of Health and Human Services goals for health of the country. And as you all can imagine, you have similar definitions in every other country. Social determinants of health here are defined as the environments in which people born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes. We all understand that food insecurity or food access is a key social determinant of health. But the point I want to make here is that it doesn't exist in isolation. Food insecurity rarely exists without a pattern of other adverse social determinants of health, some of which you can see here in this really excellent and highly reproduced model by Kaiser Family Foundation, which works on health services research in the United States. I like to think about the concept of social determinants of health through the model of the social ecological framework, the social ecological model. This is a common and simple model that can frame multiple levels of influence on health and helps us understand that individuals affect and are affected by a complex range of social influences and nested environmental interactions. Many models look like we have here. Some exclude the institutional level, but this is really the original full model produced by the CDC, or a variation of the full model produced by the CDC. And what I want to show you next is work my team has been doing based on some of our qualitative work about antenatal food insecurity. Through a series of multiple studies, interviewing participants and looking through epidemiological data, have developed this version of the social ecological model to frame antenatal food security as a complex and multi-level determinant of maternal child health. In other words, it's not just the concept of does any individual person have, for example, poor eating habits or financial barrier or disability, but really as we get to the outer layers of this onion or rainbow, we can see that things like access to transportation to safe food, access to employment, rurality versus urban status, and availability of food access programs, all of which are in these outer layers, are really essential to understanding food access. And thinking through that model helps us then contextualize some of the data I'm going to show you in the next few slides, and then think about potential interventions. So I want to take a little brief detour and talk about the concept of nutritional security and then get back to food insecurity. Nutritional security is really about the concept of your dietary quality and the idea that not just the amount of your food that you're eating, but really the nutrients within that are health promoting or affecting your health adversely. Our team at Northwestern worked with a large cohort of women through the New Mom to Be study, which was studying nulliparous pregnant people in the 2010 to 2013, and they've been followed longitudinally through their subsequent pregnancies and for their long-term cardiovascular health. In this analysis, we looked at their dietary quality in the periconceptional period, and evaluated it using the Healthy Index 2010. Healthy Eating Index 2010 grades the quality of your dietary intake on a scale of 0 to 100. And you can see here it's approximately normally distributed, with people generally eating a little better than average, but not as ideally as the US metrics would recommend. And a lower periconceptional dietary quality was associated with higher odds of multiple adverse outcomes, even after controlling for potential confounders. I think this is interesting, relevant to our discussion on food security, because it is not just about quantity and access and regularity of food intake, but really about quality in key vulnerable periods during pregnancy as well. Subsequently, there has been some really interesting work by US colleagues. Here's from Kara Dolan in Ohio, looking at some of the very limited data on food insecurity and impacts on antenatal outcomes. Some of the data she's shown here is that in this large, well, attempted to be large systematic review, they really only found 6 papers on the effect of food insecurity and adverse outcomes in the US and other high-income countries, but there were associations with some adverse pregnancy outcomes, inadequate pregnancy weight gain, iron deficiency anemia, importantly, mental health disorders, including depression and anxiety, and depressive symptoms in other subpopulations. So it's clear that maternal health is adversely affected by food insecurity, yet we don't have very large population level studies in the US looking at this on a very individual level. Along the same lines, there are data about food insecurity and its effects on adverse neonatal outcomes, not speaking to longer childhood outcomes, but really about the birth outcomes. We know that there is an association with low birth weight and small for gestational age status, as well as correspondingly less likelihood of large for gestational age status. And I think another key evidence gap here is understanding critical windows during pregnancy in which this is most important. I told you already about the importance of periconceptional dietary quality, but it's probably also true, though not as well studied, that later pregnancy periods of vulnerability for inadequate caloric intake probably also increases risk of adverse neonatal outcomes. And we just don't understand yet which are the most key windows. Transitioning to food environment, I think it's important to recognize that food insecurity is not necessarily only an individual level problem. We know that food environment is highly tied to segregation and racism. In the United States, access to high quality food stores, access to transportation to get there, and access to farmers markets is very variable based on your neighborhood income and neighborhood resources, and those neighborhood resources are highly related to racism. This is a map of the greater Houston area, a paper I really like that's older at this point, but it showed that residents in high fast food density neighborhoods was associated with an increased odds of gestational diabetes in the greater Houston area. Subsequently, there have been a number of other studies like that, including some work I've done in Chicago, some other work in California, really replicating these findings that food environments, not just individual food insecurity, is highly related to adverse pregnancy outcomes. But narrowing this down to a really small individual level, I want to talk a little bit about some of the psychosocial aspects of food insecurity. And Danielle touched on this already, but maternal social roles change dramatically during pregnancy. Here's a patient from one of my studies who had type 2 diabetes and was a parent of 3, who said the only thing that's helping me is getting what in Chicago we call a link card or a food stamp program card. But sometimes that doesn't even help, since I'm living with family and I don't have any money for myself. I'm not helping because I'm helping get food for everybody else. I have my WIC, which is a supplemental food program. I'm not eating anything out of it. I have nothing for myself. This is particularly interesting to me because WIC, which is otherwise is the shorthand for the Supplemental Nutrition Assistance Program for Women, Infants, and Children, is a program designed to provide extra nutrition resources to pregnant people and their children up through the first several years of life. Yet here is a person receiving pregnancy-specific nutrition resources who's not able to use it for herself. Another potentially unique problem that we have in the United States is the temporality of patterns of food access. In the US, at the beginning of each month, you might get your monthly government support if you are a person receiving food stamps or WIC resources. And as the month goes on and that runs out, I find in clinical practice that my patients are not eating. By the time we get to, June 20th, June 19th, even today, we're finding that patients are going hungry or saying that they're running out and needing extra food help by the end of the month because the resources are completely inadequate. So I think on that depressing note, I want to touch on emerging antenatal interventions and some areas for future work. One intervention that I think has been popular in the United States, but I have yet to see it really turning into true improvement in outcomes, is integrating universal screening into clinical practice. I particularly like this screener called the Hunger Vital Sign. So in the US, there's the US Department of Agriculture 18-item screener for families with young children. There is a smaller 6-item version, but that 18-item screener is a bit burdensome to do in clinical practice, and it can be a little bit stigmatizing to do the whole thing and know that you're getting the skip logic to answer more questions. So some researchers in pediatrics developed this 2-item version that you can see in the purple box. And that allows them to identify with very good sensitivity and specificity families who have food insecurity or are at risk of food insecurity. As a result of this research that's been done in pediatrics, it's now recommended by the American Association of Pediatrics to screen universally for food insecurity using this measure. It's not yet commonplace, though, in obstetrics and gynecology. My team is working on some testing of this, but I think we have a long ways to go before being able to fully integrate universal screening, because universal screening really demands universal access to resources, and that remains a major gap. There's a couple other programs I want to tell you about. One is called Eat SF, or San Francisco, Vouchers for Veggies. This is by a really outstanding group of food insecurity researchers led by Hilary Seligman, who has longstanding experience in community partnerships for food vouchers for low-income individuals. And their program looked at enrolling low-income Latinx and Black pregnant people into a fruit and vegetable voucher program. They got $40 each month in vouchers, $40 US, redeemable for produce, in addition to their standard WIC package. And they showed some improvements in food security, improvements in daily intake of produce, and in this really exciting prelim study, reduced odds of preterm birth. They're now expanding that to the next round of studies for hopefully bigger results in a larger population. Similarly, there's a program in the University of Michigan that I think unfortunately ended with the pandemic, but that looked at monthly home deliveries of healthy food, and they found the program was feasible and acceptable to pregnant people. And there's been, I know, a lot of research in busy urban areas about home delivery programs to get produce into people's hands without having to worry about some of the other social determinants like transportation and grocery store access that would otherwise obstruct access to those foods. And then there's the Food for Families program in Massachusetts, which is a great program in a very urban prenatal clinic that used a identification and referral program. And some of their early data showed improved antenatal blood pressure for people who were referred to the program. That subsequently has been turned into a non-research program and is really a local, highly functional referral program. But they also, excitingly, have an in-clinic food pantry, which is one of my dreams for my hospital. So what about future research? I want to end on an optimistic note that I think there's a lot we can do. I showed you this example of a food security social ecological model earlier. I put it back up again, not to say that we should tackle each one of these individually, but to say that we need multi-level interventions, and we have multi-level opportunities for intervention. From a macro level to a micro level, there is much to work on, of which some of it I'll pose here. I know that we are short on time, so I'll just tell you a few of my favorite research gaps, but I think there's a lot more that is ripe for discussion and exploration. I particularly think that the distinction between individual level food security and community level food access needs to be disentangled and studied with regard to its pregnancy and early childhood outcomes. I also think we need to understand in the role of universal screening in obstetric care, and does it do any good? Or if you can't provide resources, does it simply increase stigma? I think there's also a lot of opportunity for understanding the antenatal healthcare facility as a setting for interventions on the box on the bottom left. And that's because so many people don't access care and resources before and after pregnancy, but pregnancy is a time when people come to care and can access resources right here in our own clinics. So I'll leave you with some of those ideas. And just to conclude, we understand that food insecurity during pregnancy has short and long-term implications for maternal child health, and that it's a very hyper-local, time-varying, complex determinant. But it also doesn't occur in isolation, and other policy drivers, upstream drivers of food insecurity, really have to be addressed in order to fix the problem on a local person-to-person level. I also want to put it out there that much work has largely addressed children. Lots of the food insecurity and families literature focus on the health of the child. As a maternal fetal medicine physician, I'm uniquely interested in pregnancy, and I can see that there's a lot more that we can do and need to do. Yet there's a lot of emerging reason for me to be optimistic in this work as well. So thank you for the opportunity to join you all. I'm happy to take any questions.